Bismillah ar-Rahman ar-Rahim. Today we are going to talk about approach to acute confusion or approach to encephalopathy. We will discuss some certain terminology, then we will move on to better recognition, and we'll discuss the different flavor that encephalopathy comes with, and we will discuss some cases where we practice the different pattern recognition. So confusion is disturbance of thoughts, which is defined as the inability to maintain coherent stream of thought or action. Delirium is disturbance of attention, which is defined as an acute mental status change or change in cognition characterized by abnormal and fluctuating attention. We will explain this further later on. Usually associated with disturbance of speed, clarity, and coherence of thoughts. So the patient might speak slowly or think slowly. It is usually caused by general medical condition. However, primary CNS disorder can mimic delirium and can present also with delirium. Differential diagnosis of acute encephalopathy include vascular causes such as stroke. In particular, right parietal infarction or thalamic infarction can present with acute encephalopathy. Subdural hematoma, venous encephalopathy, venous sinus thrombosis, infectious causes such as meningoencephalitis, HIV encephalitis, infective endocarditis, CJD, non-CNS infections such as pneumonia, sepsis, and UTI, toxic etiology such as alcohol withdrawal, neuroleptic malignant syndrome, serotonin syndrome, radiation, and autoimmune encephalitis such as voltage-gated potassium channel encephalitis, NMDA receptor, anti-NMDA receptor antibody encephalitis, seronegative encephalitis, Hashimoto encephalitis, which is now called steroid responsive encephalopathy. There are metabolic and toxic causes such as hypo and hypernatremia, hypo and hypercalcemia, hypomagnesemia, and hypophosphatemia, hyperosmolar state that come with diabetes, hepatic and uremic encephalopathy, thyroid storm, and myxedema madness. Demyelinating etiology such as ADEM, acute disseminating encephalomyelitis, central pontine myelinolysis, mitochondrial causes of encephalopathy such as MELAS syndrome, mitochondrial encephalopathy with lactic acidosis and stroke symptoms. So in encephalopathy, we usually start with history, so the onset is very important. If it is sudden, it might indicate seizure, post-ictal state, or acute stroke. If it is acute and progressive, we think of infectious causes, acute disseminated encephalomyelitis. If it is hyperacute, within 1 or 2 days, so you think certainly about encephalitis, BRIS, which is posterior reversible encephalopathy syndrome associated with hypertension, which is usually caused by cyclosporine toxicity. Also neuroleptic malignant syndrome. If it is acute, over more than 2 days, but within a week. So again, you think about ADEM, acute disseminating encephalomyelitis, Wernicke's encephalopathy, Hashimoto's encephalopathies. If it is subacute, weeks to months, you think of chronic infections such as CNS infection with TB or Lyme disease. If it is chronic for several months, you think of dementia. If it is progressive and fluctuating, you think of delirium. Now we are going to discuss the different pattern of encephalopathy, or we can call it the different flavor of encephalopathy. So flavor number 1, encephalopathy with infection-like picture. So in the history and exam, we will find the patient coming with fever, in addition of course to confusion, neck pain, meningismus. So if these symptoms or signs are present, we think of meningitis, encephalitis, neuroleptic malignant syndrome, usually associated with no hyperreflexia, and that distinguish neuroleptic malignant syndrome from serotonin syndrome, where there is hyperreflexia. Or we think of thyroid storm. The second flavor is encephalopathy with sympathetic overactivity. So in the history and exam, we find the patient looks agitated, presenting with fever, very high blood pressure, and tachycardia. The differential diagnosis of this flavor include withdrawal of alcohol, benzodiazepine withdrawal, or opioid withdrawal. Also, serotonin syndrome, neuroleptic malignant syndrome, and thyroid storm is among the differential of encephalopathy with sympathetic overactivity. Third flavor, encephalopathy with temporal lobe or cortical feature without sympathetic overactivity. So in the history and exam, the patient might present with seizure, psychosis, aphasia, like paraphasic error or word finding difficulty. The differential diagnoses include encephalitis, such as infectious encephalitis with HSV encephalitis, autoimmune encephalitis such as anti-NMDA receptor antibody encephalitis, anti-voltage gated potassium channel, anti-glutamic acid decarboxylase encephalitis, anti-AMBA or anti-GABA-B encephalitis, or it could be post-ictal state. The fourth flavor is encephalopathy with brain stem features. So in the history, the patient might complain about double vision, dysarthria, gait imbalance, and in the examination, the patient might have ocular misalignment, dysarthria, truncal ataxia, limb ataxia. The differential diagnosis of this flavor includes Wernicke's encephalopathy, like vitamin B1 deficiency, ADEM, acute disseminating encephalomyelitis, central pontine myelinolysis, PML, progressive multifocal leukoencephalopathy, Bickerstaff encephalitis, venous silent thrombosis. The fifth flavor is encephalopathy with high intracranial pressure features. So in the history and exam, the patient might have headache, nausea and vomiting, transient visual obscuration, like transient loss of vision that lasts few seconds, particularly with bending forward, pulsatile tinnitus, or papilledema, or Cushing reflex, like increase in the systolic blood pressure with wide pulse pressure, bradycardia, and irregular breathing. The differential diagnoses of this category include intracranial hemorrhage, venous silent thrombosis, neoplastic such as glioblastoma multiforme or meningioma, or acute stroke with mass effect and raised intracranial pressure. The sixth flavor is encephalopathy with stroke-like symptoms. So the patient might have or might present with inability to move one arm or one leg, facial droop, or dysarthria. The differential diagnosis includes stroke, vasculitis such as SLE, vasculitis, cerebral reversible vasoconstriction syndrome, MELAS, which is mitochondrial encephalopathy with lactic acidosis and stroke-like symptoms, Hashimoto's encephalopathy. The seventh flavor is encephalopathy with abnormal movement. So the patient might present with chorea, dystonia, Parkinsonism, in addition to confusion, of course. So that could be anti-NMDA receptor encephalitis, Hashimoto's encephalitis, stroke, if it is unilateral. The eighth flavor is encephalopathy with severe headache. So we think of infectious encephalitis or subarachnoid hemorrhage. Additionally, we think about posterior reversible encephalopathy syndrome, which is hypertensive emergency, venous silent thrombosis. These are the differential for encephalopathy with severe headache. The flavor number 9, encephalopathy with myoclonus. So you think of serotonin syndrome. Usually, neuroleptic malignant syndrome doesn't cause myoclonus. You think also about metabolic encephalopathy, like uremic encephalopathy. You think about Hashimoto's encephalitis. And the flavor number 10, encephalopathy with generalized hyperreflexia. And that usually include post-ictal and Hashimoto encephalopathies and serotonin syndrome. And as we mentioned before, neuroleptic malignant syndrome usually doesn't cause hyperreflexia. Flavor number 11, which is very common, encephalopathy with metabolic features, which we call it delirium. So the patient might have reduced level of consciousness, like lethargic, and they have disturbance in the thought process and disorganized thinking. And that might present as one of the following: either confusion and incoherent stream of thoughts, rambling conversation, like doesn't mean anything, or multiple intrusion of unrelated thoughts. So the patient will talk about one topic and then jump to another topic. Perseveration and repetition. So the patient might repeat the same sentence, the same ideas, or the same words, or the same action. abnormal rate and rhythm of speech. So the patient will talk usually slowly. The patient usually has perceptual disturbance, which means hallucination and delusion. They might see unpleasant things and the patient might fight with it. Lilliputian animals or people who appear to move. The patient might complain about change in sleep and emotion. For example, they are awake all over the night and sleep during the day. Fluctuation, which means the confusion fluctuate. The patient, you feel he comes and goes. He might look much better in between the confusion episodes. They might have sundowning, which means more confusion at night after the sunset. The patient might look withdrawn, particularly in the elderly group, and they might have elementary symptoms like urinary incontinence, falls, which could be the only manifestation of delirium. So the history usually suggests the etiology. So you need to ask about predisposing factor of delirium, such as chronic illness like liver disease, renal failure, heart failure, lung disease, and thyroid diseases. Medication, like current medication list, or if some medication was introduced or discontinued recently. And here is the question: which syndrome usually develop within 6 hours from introducing or changing the medication? The answer is serotonin syndrome. Usually it's if you add another SSRI or antihistamine, they might trigger confusion within 6 hours. Presence of any kind of infection, background of dementia or malnutrition, physical restraint, using of indwelling catheters, or adding 3 new medication within 24 hours, or pain. All these are risk factors for developing delirium. And the signs of delirium include, the first thing, the most important thing, what is the hallmark of delirium? What you are going to look in the exam. So the answer is fluctuation of attention. So how we measure attention? Either by serial recitation. So we ask the patient to count from 1 to 20, or even backwards from 20 to 1. So usually patients with delirium, they might stop in the middle. So they don't continue the same task. So if you tell them count, they will count 20, 19, 18, 17, 16, 15, 14, then they stop. They don't continue. Also, another way is to ask them to do continuous performance, like they copy you. So if you clap, they clap. Or, for example, you tell them, I will mention group of letters. Once I mention the letter A, you clap. So they do it initially correctly, then in the middle of the task, they don't clap when you mention the letter A. Or alternative response task. So you tell the patient, if I clap once, you clap once. If I clap twice, you don't clap. So they might not able to follow that instruction. And the most important thing is the patient interviewable or not. So they might take too long to answer the question. It might be very difficult to interview them. And they might have disorientation and memory loss. So they might think they are in a different space. And there is something called reduplicative paramnesia, which means the patient think he is in the city that he usually used to live most of his life. So if he used to live, for example, in Riyadh most of his life, and he is currently in Jeddah, you ask him, where are you now? He will say Riyadh. He doesn't remember that he moved to Jeddah. They might have also postural tremor, which is another sign of delirium. So if we summarize the most common flavor of encephalopathy, we mentioned more than 10 flavor or 11, and the most common of them is encephalopathy with infection-like feature, with sympathetic overactivity, confusion, or encephalopathy with temporal lobe feature without sympathetic overactivity, encephalopathy with high ICP, intracranial pressure feature, brainstem feature, and the one that associated with no neurological symptoms except for tremor, or signs except for tremor, and that's usually delirium. So workup, usually we send for CBC, we send for electrolyte to check for magnesium or potassium or calcium disturbance or phosphate. We check the renal function, creatinine, urea, ammonia, liver enzymes, and arterial blood gas. We check the CK level, which is usually elevated. The CK level or creatinine kinase elevated in neuroleptic malignant syndrome. We send for septic workup with urine analysis, chest X-ray, blood culture. We might, or we definitely we go for CT brain plus or minus CT angio or CT venogram, depending on the clinical assessments. We do lumbar puncture if indicated, or if there is suspicion of meningoencephalitis. We check lactate level because it's elevated in mitochondrial disorder. We check the electroencephalography, EEG. We order MRI, and we order serological antibodies for autoimmune encephalitis if indicated, and that include anti-glutamic acid decarboxylase antibody, anti-NMDA receptor antibody, anti-voltage gated potassium channel antibodies, and anti-thyroglobulin antibody, and anti-thyroperoxidase antibodies for Hashimoto's encephalitis, which is called steroid responsive encephalopathy. So the first case, 57-year-old, previously healthy woman. She presented with one-day history of headache and atypical behavior. Her family report that she exhibited confusion, garbled speech during the last 6 hours. Patient complained of a funny smell, burning candy over the past day. Has been noted new lesion in her lips, and in ER they witnessed complex partial seizure defined by right clonic movement succeeded by generalized tonic-clonic seizure for 1 minute followed by somnolence. So if we recall, this might call so far encephalopathy with temporal lobe feature, because there is abnormal behavior like psychotic manifestation, or also hallucination, which is, and seizure, which is temporal lobe feature, like the gustatory hallucination, smelling something. On the vital sign, the blood pressure was 110/70, heart rate was tachycardic, elevated temperature at 40 degrees, and tachypneic slightly. General examination showed vesicle on her lower lips. There is knuckle rigidity, disoriented to time, place, and person. There is dysphasia. She doesn't have recollection, and there is no registration. So if you give her 3 words, she cannot give it back to you. Unable to consistently follow command. When you do the motor exam, there is pronator drift on the right side. Unable to walk, and the reflexes were normal. So differential diagnosis, we have encephalopathy with infection-like picture as well as temporal lobe feature. So that's on the top of that, that's HSV encephalitis, or infectious viral encephalitis, or meningitis. Also brain abscess, subdural empyema because of the infection of the temperature, and serotonin syndrome, neuroleptic malignant syndrome. All these can cause elevated body temperature. So what you are going to do? Usually in cases when you suspect meningoencephalitis, the first thing you do, you take blood culture, which is positive in 60%, and you immediately start anti-meningoencephalitis regimen. Immediately. You don't wait for anything. You do these 2 steps, blood culture plus anti-meningoencephalitis treatment immediately. So you give ceftriaxone 2 gram IV Q12 hour, vancomycin 1 gram IV Q12 hours, acyclovir 800 mg Q8 hours, dexamethasone 10 mg Q6 hours, ampicillin 1 gram IV Q4 hours. And the investigation, you definitely will get CT brain, but always, then you proceed with lumbar puncture. But there are certain indications that mandate that you have to get CT brain, which is usually we do anyway, but in this situation it is more needed. If there is the patient in coma, or if there is focal deficit like arm weakness, leg weakness, aphasia, or if there is seizure, or there is papilledema, or an elderly patient, or with immunocompetent. So these are stronger indication for CT before LB. However, we always get CT before LB. So we did CT brain, and there is hypodensity here in the mesial temporal lobe on the right, which also are signs of meningoencephalitis. The CSF showed WBC of 110, 90% lymphocyte, protein elevated at 2.9 gram, glucose was 5, gram stain was negative, viral PCR was sent. So most likely it was HSV encephalitis. So what's the prognosis? Before antiviral treatment was discovered, the mortality was 70%. However, now it is 2.5%. sorry, correction, mortality 70% with 2.5% chance of complete recovery. After the antiviral was introduced, 65% they have favorable outcome and 14% full recovery. So the patient was in the hospital and the nurse called you because the patient is unresponsive. So the motor exam showed only withdrawal to pain, verbal was incomprehensible speech, eyes open to pain only, pupil, there is right dilated pupil and fixed. The corneal and gag were normal and the oculocephalic reflex was normal. Right side upgoing plantar response. So positive or present Babinski on the right. So what's the differential? First, ankle herniation from the mass effect and vasogenic edema. Or it could be seizures, or it could be cerebral infarction from HSV infection itself, or it could be intracranial hemorrhage, secondary complication to HSV encephalitis, or venous side thrombosis, or the patient could have developed acute hydrocephalus. So these are the differential diagnoses. So there is physical sign that confirm one of these, which is dilated pupil. Once there is dilated pupil, you think about ankle herniation, and there is the reason. This is in yellow circle, it's the ancus. This imaginary yellow line is the course of the third cranial nerve. It goes from the midbrain to the orbit. So what happened, this is the ancus. When there is raise in the cranial pressure, the brain tries to escape. And one of the orifices that the brain can escape from is the ancus. It's easier pathway to escape to the ambient cistern. The cistern in front of the midbrain, we call it ambient cistern. And once it protrudes, the ancus is protruded and it compresses the third cranial nerve. So you get dilated pupil on that side. So that's why it's very important to check the pupil when someone has decreased level of consciousness to make sure they are not about to have ankle herniation. There are several herniation syndrome, including ankle herniation, which is characterized by ipsilateral dilated pupil, hemiparesis, ipsilateral, or it could be contralateral. They might have this ipsilateral because if the ankle compress the ipsilateral cerebral peduncle, it causes contralateral weakness. If the ancus pushed the whole midbrain to the other side cerebral peduncle will be compressed, and that will produce ipsilateral weakness. There is another syndrome called central herniation, which basically the thalamus goes down to the midbrain and the brainstem, which is called transtentorial descending bilateral herniation. The patient will have mid-sized fixed pupil bilaterally. They have coma, of course. They have Chine-Stokes respiration. The tensular herniation, they present with hypertension, bradycardia, bradypnea, and respiratory arrest. Subfalcine herniation, they present with contralateral leg weakness. So what do you do next? We think of ankle herniation, so we give DIXA, mannitol IV, intubate and hyperventilate, and stat images. And what we see here, the ancus herniation. The ancus protruded and compressed. This is the midbrain, and it compressed the cerebral peduncle here. Cerebral, not cerebellar, cerebral peduncle. And if it compresses the ipsilateral cerebral peduncle, it will cause, for example here, the right ancus compress the right cerebral peduncle, it will cause right leg weakness or right-sided weakness. If the whole midbrain was pushed, so there is a chance that this cerebral peduncle on the left side get compressed against this meningeal edge. And when it compressed, the left side cerebral peduncle is compressed against this meningeal edge, it would cause right arm and leg weakness. So the imaging feature suggests of ankle herniation, asymmetry of ampial cistern, like here, there is loss of ampial cistern here while it's present the other side. Widening of contralateral temporal horn. So this is the temporal horn here and here. So it's not obvious in this picture, but sometimes this temporal horn become very large. Herniated brain is forced medially and inferiorly. beneath the tentorium into perimesencephalic cistern, compression of ipsilateral cerebral peduncle by the ancus, compression of the contralateral cerebral peduncle against the tentorial edge. We call this Conahan notch. We explained this in the previous slide. Ankle herniation complication. There are certain complications to the ancus when it herniates. It causes focal infarction of the ancus and parahippocampal gyrus. It causes infarction by compression of the posterior cerebral artery, and that will cause PCA territory infarction. Infarction by direct compression of the anterior caudal artery. And they might cause hemorrhage in the midbrain. And that hemorrhage, it has a name, it's called Dorette hemorrhage. Dorette hemorrhage. So the management, you call the neurosurgeon for the compressive craniectomy. So we assume the patient had the surgeon and the patient woke up. So how long you will continue antiviral for HSV encephalitis? For 21 days, IV. The second case, 60-year-old man admitted for COPD exacerbation, and the medication list includes citalopram for depression. Next day found to be confused. And on the exam, temperature was elevated at 38 degrees, pulse was elevated at 105, blood pressure was hypertensive at 150/90. There is decreased level of conscious, disorientation, and low attention span. The pupil was dilated and was hyperreflexic. So there is picture of encephalopathy with infection-like presentation as well as sympathetic overactivity. And when we have these two combination, we think of medication like serotonin syndrome or neuroleptic malignant syndrome. So we have to review the medication chart, and the patient was started on dancitron in the last 12 hours. So the diagnosis is serotonin syndrome. The management, you give benzodiazepine, cyproheptadine 12 mg initially, then 2 mg Q2 hours, or you give olanzapine 10 mg, or chlorpromazine 50 to 10 or 100 mg. Here is again the differential diagnosis of serotonin syndrome, which include neuroleptic malignant syndrome, anticholinergic syndrome, or malignant hyperthermia. With serotonin, there is large pupil, while in neuroleptic malignant syndrome, the pupil was normal. In serotonin syndrome, you have hyperactive bowel sound, while it is normal in the neuroleptic malignant syndrome. Usually in the serotonin syndrome, there is hyperreflexia, while the reflexes is reduced in neuroleptic malignant syndrome. Also, there is other differential diagnosis like with opioid withdrawal and other things, and this table from up to date that compare all these different differential diagnoses. So the third case, 64-year-old woman with 2 days history of dysarthria, binocular horizontal diplopia, and on the third day she developed blindness in the left eye, and on the following day the blindness in the right eye. Her husband noticed that she was confused and not making sense. So neurological examination, she scored 24 out of 28 in mental status examination. She was unable to count from 20 backward to 1. Her light perception, she has reduced vision with only light perception on the right eye and no light perception in the left eye. Pupils were non-reactive with no relative afferent pupillary defect. Fundoscopy revealed bilateral papilledema and hemorrhages. The rest of the examination showed left-sided deviated tongue and unsteady gait with negative Romberg. So what category this patient fit? It fit with encephalopathy with brainstem features and also blindness. So the brainstem feature, we mentioned that it could be ADEM, acute disseminated encephalomyelitis, Wernicke's encephalopathy, central pontine myelinolysis, or PML. However, because there is blindness, so that make the ADEM more highly in the list, followed by PML, progressive multifocal leukoencephalopathy. Her lab investigation shows unrevocable ESR and CRP and ANA and complement and anti-double-strand DNA. CSF showed negative for oligoclonal band. Protein was slightly elevated at 0.58 gram. WBC count was elevated at 3.9. CSF cytology and flow cytometry were negative. Serological study was negative for varicella, hepatitis, HIV, cryptococcus, and histoplasmosis, and also viral causes such as CMV, EBV, HSV, enterovirus, or SNAL virus. Anti-aquaporin 4 was negative. The MRI shows demyelinating lesion in the corpus callosum as well as the midbrain. some of them were enhancing, and there is enhancement of the optic nerve. So all these features confirm the presence of demyelination, and it's in the clinical context suggestive of ADEM, acute disseminated encephalomyelitis. So the diagnosis of acute disseminated encephalomyelitis was made, and the patient was given intravenous methylprednisone 1 gram for 5 days and oral prednisone 1 milligram per kilogram per day. Or you can give intravenous immunoglobulin 2 gram per kilogram over 5 days. So you give IV methylprednisone for 5 days followed by oral prednisone, and also you give intravenous immunoglobulin. The fourth case, 44-year-old right-handed woman with 5 days history of progressive gait imbalance, 1 day history of confusion and hallucination, and 1 generalized tonic-clonic seizure, no significant past medical history or medication, physical exam shows normal vital, inattentive, she was agitated, and there was no focal finding. So we see here that she has encephalopathy with temporal lobe feature with hallucination and seizure, and there is hyperreflexia. So predominantly temporal lobe and brainstem feature. The differential diagnosis include autoimmune or infectious encephalitis. Which favor one over the other? The temporal cause. Since it's over, as we mentioned here, it's over 5 days, so it might be more of autoimmune encephalitis. However, infectious causes still remain on the list and need to be excluded. So the metabolic workup was negative. She has high anti-peroxidase antibody, and EEG showed FERDA. So the MRI showed white matter lesion. So she was diagnosed with Hashimoto's encephalopathy based on the serological testing. She was treated with prednisone 50 milligram with gradually tapered down, and she had frequent relapse. So she was started in Imuran with no further relapse. All these cases I am presenting today, they are real, so I'm just presenting their real course. So the last case is the fifth case. 23-year-old woman, right-handed, nursing student. She has chronic daily headache for 10 years, previously investigated and managed with Percocet, which is oxycodone, for 6 years. On December 2009, she developed intermittent rash involving the trunk and both lower limbs. On February 2010, she developed new left hand weakness, numbness, drowsiness, and presented to ER. No other neurological symptoms. No seizure, visual symptoms, bulbar weakness, or other limb symptoms. No other systemic symptoms. And on examination, she has elevated blood pressure at 150/200 over 100 to 130 millimeter mercury. Skin exam revealed blanchable maculopapular red rash on the palms and the leg. Mental status, she was drowsy and able to follow conversation. Visual acuity was 20/40 bilaterally, so she has reduced vision, and there is left-sided weakness, especially in the hands, with upgoing toe on the right. So she has multifocal localization. So where is the localization? There is confusion, which indicate bilateral cerebral cortex involvement. There is right upgoing toe and left weakness, which indicate multifocal involvement. There is decreased vision, which indicate cortical with no RABD, so that might be cortical vision loss. Which category this patient fits in? Usually multifocal stroke and cortical blindness. What other important feature on the exam? She has very high blood pressure, so you have to think about PRES, posterior reversible encephalopathy syndrome. She has headache and rash, so you have to think about vasculitis. Headache suggestive of vasculitis, and rash also suggestive of vasculitis. So she was investigated, and the investigation revealed mild anemia, and there is mild leukocytosis, normal platelet, light and creatinine were normal, ESR was elevated, she was not pregnant, and urine analysis shows RBC, WBC with mild protein. So she might have nephrotic involvement. CT brain, as you see here, there is this subcortical hypodensity sparing the cortex. When it spares the cortex, that means the edema here is vasogenic, which means it is not stroke, because stroke usually causes cytotoxic edema. Cytotoxic edema affect also the cortex, but here we see the cortex are spared. On MRI, there is white matter changes with the bright signal on the DWI sequence, but no corresponding ADC map hypodensity, so there is no diffusion restriction. So these findings suggestive of PRES, posterior reversible encephalopathy. When you have subcortical hypodensity sparing the cortex, suggestive of vasogenic edema, and confirmed on MRI by lack of DWI restricted diffusion, that's suggestive of posterior reversible encephalopathy. And when we did MRI with contrast, we noticed that there is, you compare the transverse sinus on the left, which is normal filling, and on the right there is filling defects here, also here and here. The left is normal, filling normally, while the right there is filling defect. So she has cerebral venous sinus thrombosis, and she has breast posterior reversible encephalopathy syndrome. And there is also enhancement here, which means there is some sort of infarction. So she was diagnosed with SLE because her ANA was strongly positive, and she has SLE vasculitis, and she has breast and cerebral venous sinus thrombosis. She was treated acutely with steroid, heparin for the venous sinus thrombosis, steroid for the vasculitis, and antihypertensive for the posterior reversible encephalopathy syndrome. And that's the end of the presentation. Thank you very much.